So the talk today is on abdominal cerebrospinal fluid pseudocysts. And the objectives are just to talk about what they are, what we know about them, how are they treated traditionally, and how can they potentially be treated. And then the final question is, do all pseudocysts need to be treated by explanting the whole shunt, or at least taking out the distal end of the shunt out of the peritoneal space? So this is a modern BP shunt on the left and a shunt series X-ray of the shunt on the right. The first BP, or the first CSF space to peritoneal shunt, was described in 1898 and was a silver wire that tunneled from the lumbar cistern ventrally into the peritoneal space. And the two cases that were described, one patient died soon after, and then the other patient did well for about 3 months and then died. And then other attempts mostly involved wires to create a scar tract for the CSF to drain through, and there was a high morbidity, so the technique was abandoned, and then gained traction again in the early 1950s and quickly evolved into their modern form. The most common shunt complication is a proximal obstruction. Distal complications are less common, but one complication that's been around as long as modern shunt is the abdominal cerebrospinal fluid cyst, where a loculated cavity forms around the distal end of the catheter, so it can't drain well. And the first known pseudocyst in the literature is in 1954. This is a large pseudocyst. The shunt tubing's coiled in the lower abdomen that you can see on the CT. And anatomically, a true cyst is an epithelium-lined fluid-filled cavity. A pseudocyst is not lined with epithelium, it's a fluid-filled cavity. The consistent pathologic finding on studies of these is that there's a non-epithelial inflammatory surface that isn't made to absorb fluid. When would you suspect a pseudocyst? If there are symptoms of shunt malfunction, there are also usually abdominal symptoms like abdominal pain or abdominal distension. If you're working up a shunt for a malfunction and you tap the shunt and there's good proximal flow, but a high opening pressure. So the next step in the shunt workup at that point, if you suspect one, is to perform an abdominal ultrasound. CT can be done, but abdominal ultrasounds are adequate almost all of the time. And just a note, it's normal to have some free fluid on an abdominal ultrasound of a working shunt. So in the literature, there's about a 1 to 7% published incidence of these. They recur about 18 to 50% of the time if they're reimplanted into the peritoneum. And the infection rate ranges from 8 to 100% depending on the study. And I put a table up here from a review study just to show the range in infection rates. It's pretty big. One question that we have, are all pseudocysts actively infected at the time of diagnosis? And the answer is, based on what we know, is no. And then where it gets interesting is if they're not all infected, do we have to treat them all like infections, or can they be treated by leaving the shunt in for certain pseudocysts? Risk factors for pseudocyst formation are recent abdominal surgery like G-tube appendectomy, shunt infections, prior major abdominal surgery like necrotizing enterocolitis in preemie babies, or on our experience, potentially like a sterile viral gastroenteritis or a spontaneous bacterial peritonitis. All these things have caused scarring or inflammation in the peritoneal space. And so probably pseudocysts start due to an infection at some point, but are they all actively infected at the time they're diagnosed? And if not, then what options are there to manage them? So just to real important, is an infected pseudocyst where it's culture positive, do you have to treat it with shunt explant? Absolutely, yes. It's an infected shunt. You need to take it out, put in an EVD, give IV antibiotics, and reimplant later. Is the peritoneal space a good reimplant option? It usually is. You haven't burned a bridge just having had a pseudocyst form. Once it resolves and it's treated, most of the time you can put the shunt back in the peritoneal space, and for especially young children, but for most people, that's still a better option than putting it somewhere else, like in the atrium or gallbladder or pleura. So then now getting into this question again, if you're pretty sure that the pseudocyst is not actively infected, you have to explant the whole shunt. It's a big ordeal for a patient to go through to have a shunt explant, and especially on kids that don't understand, or developmentally delayed adults, or people with very small dysmorphic ventricles, taking a shunt out and then putting it in 2 weeks later, and that whole process it's a big deal. So to answer that question, we looked back at the experience at Dallas Children's here over the last all available pseudocyst diagnosis for the past 30 years that spanned the careers of 10 pediatric neurosurgeons, and we found 92 patients who presented for the first time with a pseudocyst, never having had one before. And of those patients, there were 136 total admissions for treatment of pseudocysts, so some of those were recurrent pseudocysts. And I want to thank my colleagues, Drs. Price, Whittemore, Braga, Solero, Sklar, and Swift for their thoughtful management of these pseudocysts, and in particular, Dr. Swift for really figuring this out and promoting this alternative management of keeping the shunt in and seeing that this works for certain patients. So this practice has the hypothesis that certain pseudocysts, which I'll define as we go through our data, can be effectively treated without externalizing any part of the shunt. The advantage to that is that it's a shorter hospital stay. It's a single surgery for the patient, and it's much less traumatic, much less of an ordeal than a whole shunt explant approach. Traditionally, reading about when pseudocysts are defined as an active infection, taking the shunt out, that's the traditional way to treat these. So the technique here is called laparoscopic repositioning. And when we think that a patient does not have an actively infected pseudocyst that could be treated this way, we call the general surgeon. They gain access to the peritoneal space, lyse adhesions, open the pseudocyst, and then reposition the distal shunt catheter in the peritoneal space. And during that time, we're treating with empiric antibiotics. There's a handful of case reports and small case series on this, but no follow-up. And so the really neat thing about looking back at this practice's data is that there's many years of follow-up on a relatively large number of patients. This is what it looks like from the general surgeon's point of view. Starting in the top left, they gain access to the peritoneal space. You can see some peritoneal adhesions. They put in another port to lyse the adhesions, and then start creating a bigger space in the peritoneal cavity. And you can see a drop of CSF coming from the distal shunt catheter once it's been located and repositioned. So I'll present some of our data. This is just scratching the surface of this data set, but some of the interesting highlights. Most patients were prematurely born with interventricular hemorrhage of prematurity. Second place is myelomeningocele patients. Most of these patients underwent shunt placement during infancy. The pseudocyst presentation age was between 11 and 12 years old, but there was quite a bit of a spread in that. And then as far as follow-up on the lower right table, for all first-time pseudocysts that did not recur, in 59 out of 69 of those patients, we had over 6 years of follow-up. And then in the laparoscopic repositioning subset, first-time pseudocysts, 20 out of 22 of them, we had over 5 years of follow-up. And then in the orange circles, I just wanted to highlight that when pseudocysts do recur, they recur relatively quickly after you've treated them the first time in roughly 2 months or less. The histogram on the left, the blue bars just represent the number of patients over each 5-year period that presented with the first pseudocyst. The red bars are patients that presented were treated for recurrences. And then on the right histogram, it's the number of prior pseudocysts. So 0 means first-time recurrences, so we're in the low 90s, and then about 34% recurred. And this is for all treatment methods. Symptoms we talked about a little bit earlier, but this is broken down on the left. 2 darker gray colors represent first-time pseudocysts that were culture positive and negative, and then the right 2 colors are the recurrent pseudocysts, culture positive and negative. So I think the point here is just that you can have a range of symptoms, whether their patients are culture positive or negative. Abdominal pain, nausea, vomiting, abdominal distension is more common in sterile pseudocysts. Fever is more in non-sterile pseudocysts. You can have all sorts of symptoms of shunt malfunction. This is our data for all first-time pseudocysts. How are they treated in the cumulative counts of each treatment method over time? The first thing to notice here is just that there's 17 different colors on this graph, and so there are many variations of how a pseudocyst can be approached, and so that's because there's heterogeneous comorbidity, presentation, patient issues, and surgeon preference, and so the data sets, there's a range of the way people approach this that wasn't standardized, but the most common way to treat this was with curve 3, which was laparoscopic repositioning, and then explant, EVD, or peritoneal reimplant is curve 1, and the other curves, a lot of them are peritoneal reimplants, and they did well. This is treating recurrences. Curve 5 is revising to a non-peritoneal terminus, but the other curves, a number of patients were treated with putting the shunt back into the peritoneal space on the recurrences. Curve 6 is ETV, so the way that some patients, 4 out of this whole data set, were treated with an ETV and the shunt was ultimately removed. Another way to look at this data is we did this with a Sankey diagram, which just shows the flow of how patients were treated, starting on the left with breaking that initial presentation group into culture negative pseudocysts and culture positive. Most were culture negative. There are 3 general strategies. You can explant and then place an EVD. You can externalize the distal end. You can leave it in the body. And after that, you can either put it back in the peritoneum or in another space like the pleura or atrium or gallbladder. And just the takeaway from this slide is that looking at most culture negatives, that widest band flowed into the laparoscopic repositioning approach. And then out of that, about 2/3 of laparoscopic repositioning did not have recurrence, about 1/3 did. Of those recurrent patients, 19 out of the 23 did not have an infection. 7 of those at the recurrence had an infection. So sometimes infection, the cultures are not completely sensitive. Out of the culture positive patients, most of those were treated with explant, EVD, and peritoneal reimplantation. In all 3 of these approaches, sometimes the surgeon decided to implant the distal catheter, but not in the peritoneal space. This is our infection data. So the yellow circles in that top left table show the percent of patients that got either a shunt tap, 87%, or a tap of the pseudocyst by interventional radiology, about 60%. And we had relatively low culture positive rates on these taps. But I think the first thing with the pseudocyst is to establish whether the shunt is infected, the whole shunt is infected or not. And then most of the infections were type of staph were P. acnes. Shunt survival or pseudocyst recurrence, survival analysis of that. And so the event of interest is after treatment, does the pseudocyst recur when the shunt was reimplanted back into the abdomen? So the top curve is the gold standard explant EVD peritoneal reimplant once the pseudocyst is gone. And there's about a 90% recurrence, I'm sorry, a 90% success rate with that. And this is over 1 year. The next curve is explanting the EVD from the peritoneal space, which also did well. And then keeping the shunts in situ and just moving them were not as successful in general. So lap repositioning is blue, and then some other version of moving the shunt is in purple. This is combining just the idea of taking it out of the peritoneal space, whether you're explanting the shunt or just externalizing versus leaving it in place. And these are significantly different with a log rank test. So we looked through a lot of different factors, risk factors like prior surgeries on the abdomen, number of shunt revisions, prior shunt infections, age, and type of hydrocephalus, and didn't find anything that reliably predicted that the pseudocysts would recur in any form of treatment until we got to looking at inflammatory markers. So white blood cell count, ESR, and CRP. And so this is a plot of all first-time pseudocysts, all treatments. And if the inflammatory markers were known to be true, we plotted them in blue. And those patients did not do as well as those that were known to be false, or we just didn't know. The ones where we just didn't have that data were included in the red plot. Taking out the patients where we didn't know what their inflammatory marker status was in this long retrospective review, looking at a Fisher analysis, if we knew the inflammatory markers, we did see that there is a significant difference between high inflammatory markers or low inflammatory markers in recurrence. So if inflammatory markers were low, there is a much lower chance of the pseudocyst recurring. And that's for all treatment types. Specifically with laparoscopic repositioning, with that approach, this is the blue in this survival curve is known high inflammatory markers. And I wrote the criteria in the upper right of the slide, so a high white count, ESR, CRP. And then the red curve is either known low inflammatory markers, or we just didn't have that data, so it was imputed as high. So the survival rate here was 50% if the inflammatory markers were high versus 75% if they weren't. And that wasn't significant on a log rank test, but it was a trend towards that. Taking out the patients we didn't know their inflammatory marker status, there's a similar proportion of recurrences in those 23 patients versus the 35 laparoscopic repositioning patients, and we did find a significant difference based on breaking them down by inflammatory marker status. Though the numbers were lower, there's still many more patients in these groups than anything out there that's been put together before. So this is looking at the length of hospital stay for these patients. Each approach, so externalize EVD peritoneal reimplant is on the left, followed by externalize, some version of keeping in situ, and then lap repositioning is on the right. These shapes just represent the distribution of the length of stay of these patients, and then the bars on top represent the p-values from a Mann-Whitney test comparing the length of stay. And the key thing here is that for laparoscopic repositioning, the mean length of stay is about 6.5 days, and that was significantly different from the other methods where you explant the distal shunt or explant the whole shunt. And so our data did find that we had a much shorter length of stay with the lap repositioning. So to sum it up, just putting the survival together, our gold standard of explant, EVD, peritoneal reimplant, the red curve, and the blue curve is laparoscopic repositioning with low inflammatory markers. There was not a significant difference. There's a trend towards lap repositioning not doing quite as well. But for sterile pseudocysts, this is still pretty good. And for these patients where it's a huge ordeal to put them through a shunt explant, in our practice, we feel like it's been worth it for select patients to use that approach. The biggest study out there on sterile pseudocysts had 28 patients, 11 that were sterile, 11 were put back into the peritoneal space, and they had an 82% success rate at 2 months. Whereas with a larger data set, longer follow-up, we're getting 75%. This is the approach that we have, just summing all of that up, that if you suspect a pseudocyst, check an abdominal ultrasound, and if the cyst is present on the ultrasound, then tap the shunt. Also ask IR to tap the pseudocyst if it's possible. If there are any signs of infection, explant the shunt. But if there's not, then check inflammatory markers. And if they're low, consider laparoscopic repositioning at about 48 hours and 7 days of IV empiric antibiotics. So that's a summary of what we have. Are there any questions?
Hey, Brett, that's an interesting data set. You know, the P. acnes is one of the most common organisms for these pseudocysts, it seems, and they're somewhat fastidious to grow in the lab. So I wonder how reliable the cultures are. I guess the inflammatory markers probably add some sensitivity and specificity to it.
Yeah, it's you have the lab hold the cultures for a week. Something I didn't go into is that 2 of the lap repositioning failures were infections that were discovered late after the procedure was done. In general, it seemed like looking at the inflammatory markers was a sensitive enough test for a potential problem with CSF absorption that it still played out well with the outcomes, but that is a difficult part of managing these patients and making a decision like this.
I think one thing to note is that there's a general belief that perhaps all of these are infected. You just can't find the organism, so therefore you have to explant them all. And that may be, but the infection may be so indolent that you eradicate it just simply by moving the shunt and getting rid of the fluid space. The infection part's a really hard one. Do you think the infection comes first, or do you think what do you think the etiology of the pseudocyst is, Brett? In a patient who's not obviously infected.
I think it's the infection comes first, or they're not absorbing CSF great in the first place, but well enough, and some process that causes inflammation in their peritoneal space, whether it's an infection, or we've seen patients with a few with like a gastroenteritis that then come in with a pseudocyst. Something tips that over and they develop it. They're probably seeded with infection somehow. What do you think?
So if we have a situation where you have a gold standard that does pretty well, and then you have something that does almost as well, but it results in a shorter length of stay. So economically, it's an improvement. But how will we decide whether or not it's worth it, because it's not quite as good? Was there any permanent morbidity associated with the recurrences? First of all, was it dangerous to have a recurrence?
No, it wasn't dangerous. It just is more days in the hospital, more surgical procedures. Although this is repositioning the shunt catheter for these patients is relatively benign compared to trying to explant the shunt, have an EVD in a lot of these patients for a couple weeks, and then getting a working shunt back in. But there's no permanent morbidity that we found in this data from doing it this way.
Well, I appreciate you working that up. That's going to be an important algorithm for us to use in the future.
I have a question, Brad.
Yeah.
A couple questions. The first thing is, it seems like, based on this, very, very good for the literature retrospective data set, you've identified key factors you'd want to look at prospectively. And I think you certainly have equipoise to assign them randomly here, in terms of the outcome, but to the full explant versus sterile pseudocyst exploration approach. What factors you would need to make sure are balanced in your randomized groups, and that I think would be. Are you thinking about doing that?
Short answer is no. I think these patients, there are a couple of reasons for that. I mean, we could. It's a good thought. I think it would be very, very hard to control the issues here, to have a real true comparison between all these and to get enough patients where we could make a meaningful conclusion. There's a lot of variability.
But all you have to show is, you only have to show non-inferiority. So your power calculation is not as onerous, You don't have to show superiority. Or
true.
I would think about it, because I think that would be a really, that would be like, PCORI level fundable, to do a randomized study like that. Even if you had some pilot randomized data, I think it'd be fundable. The second question, just because I've been banging on the drum of Kaplan-Meier curves and informative censoring, do you want to talk a little bit about any censoring you had in your Kaplan-Meier curves? It looked pretty good, like you didn't have very many that fell out for any reason other than the relevant variable, the outcome of interest. But maybe you could just touch on that for the resident benefit.
Hey, yeah, Brad, could you say a little louder what specifically about the Kaplan-Meier? I couldn't hear very well.
Sure. I've just, at Journal Club, I've been banging the drum that we look at Kaplan-Meier curves. You have to pay attention to the number of patients that are censored for reasons that are supposedly non-informative, meaning they don't fall into the, failure or non-failure group. They get censored because they just drop out for other reasons. And you have to look at, match and making sure that the censoring was balanced between your two groups meaning the non-informative censoring, the censoring for other reasons other than your outcome. I was just wondering when you constructed the curves, if you talk about some of that, or did you run into any problems with dropout? And I don't know. It could be. It looks to me, it looks like a strength of your data. You don't have much of that. Yeah,
I think as far as censoring and how balanced all that was, I didn't look at that quantitatively because we had such good follow-up for most of the patients. Like for the laparoscopic repositioning at 1 year, which was our endpoint to look for recurrence, 90% of those patients we had all that follow-up data for, and not much less than that for the other approaches. And so the patients, I put some of the tick marks on the graphs for when they were right censored, but there weren't that many there.
This seems to be more of a pediatric problem than an adult problem. Dr. White, is that true from your standpoint?
We see a not insignificant number of pseudocysts each year, maybe I don't know, 4 or 5 a year. And I'm not sure, the ones that are happen right after the shunt's done within a couple of months seem to make sense as infection. The ones that happen years later, it's hard for me to understand exactly why all of a sudden they're not absorbing their CSF anymore.
Yeah, that's the main issue we're trying to get at. Those are the ones that we're very interested in. We think we can get away without explantation. So,
Yeah.
Brett, thank you very much. That was great.
Thank
Look
you.
forward to finishing off with you.